My name is Doug LaPlante. In today's EH&S discussion, Environmental Health and Safety, we're going to talk about the impact occupational medicine has in the construction industry. And joining us today is the principal at OccMed CIC, Dr. John Burress. And I know John is widely used through the New England area to help the construction industry with all different ranges of occupational medicine, from preventative measures to reactive measures after an injury. So we're going to be interviewing and talking with John today and just discuss the impacts that occupational medicine has on the construction industry. Before we get started, though, I do want John to introduce himself. So John, without further ado, if you could tell us a little bit about yourself and your past and
Sure.
a little bit about the practice.
Yes. So I started this company 8 years ago after having a 10-year stint at Boston Medical Center. By way of background, I did family medicine residency in Greenville, South Carolina, and then I did a fellowship at the Harvard School of Public Health in occupational medicine, and am board certified in occupational medicine, and have been practicing mostly in the community setting, but with the exception of 10 years at a medical center. And of that time, most of it in Massachusetts.
Okay.
It was actually Turner Construction. I had helped them before I went to Boston Medical Center, and then with the National Emerging Infectious Disease Lab, you guys did that project. It was Jamie Evans that came and said, "Can you help us with this?" And I got permission from the hierarchy at Boston Medical Center, and that was the start of my emergence, if you will, with the construction trades.
What year was that? Do you remember?
About 2006,
Okay.
2000, something like that.
Yeah.
During the Big Dig, at that time, there were 2 group practices of OccMed. The Baptist had about 8 clinics, and something called OH&R had a number of clinics. Now, neither exists.
Sure.
And I can explain that in a little bit. But again, as introduction, 8 years ago I started this company because I saw a deficit in terms of people who were passionate about injury care. And there was no real viable economic model to supply that care. So I came up with, with a different way of skinning that cat, so to speak.
Sure.
And thanks to companies like yours and several others, I've now grown this company to service about $8 billion worth of ongoing construction.
Wow.
One reason why construction matches my own philosophies is the incentives are aligned. For me to provide excellent care equates to and translates to money saved on the part of the construction trades. And we can put a finer point on that.
Absolutely. So, we talk about occupational medicine, and that word is thrown around: occupational medicine, occupational facilities. What does that mean? How would you define what occupational medicine is?
So there's actually a field called occupational and environmental medicine. It's a field like cardiology. It has a board exam that people have to sit. You have to qualify for it. There's not a great number of people who are in this field, but for those who are in it, we think it's great.
Sure.
And it's a field that encompasses a broad scope of medical issues, from musculoskeletal to respiratory to dermatology, and it's a wonderful bridge between industrial hygiene, legal medicine, engineering.
Sure.
The clinical entities that I see are varied enough. I'm not just scoping someone's colon every day,
Sure.
right? I'm doing different things. I feel like I'm pretty accomplished with soft tissue injuries, musculoskeletal strains, sprains, etc. And in the clinic that I have here, I maintain very good backup. And so I probably take care of a greater level of acuity, of severity, than most.
Okay.
Certainly more than the average urgent care provider.
Yes.
The level of suturing I do is way beyond what an urgent care provider would do, and probably is beyond what most emergency room physicians would do.
Yeah. Well, I appreciate your sensitivity to the patient that comes in. When in the past, when a construction company, as my company would have to do, is send somebody to an emergency room. They were just a number. They were trying to process as fast as they could, and they weren't given any kind of real diagnosis. It was, you're fine enough, you don't need our emergency services, go see your primary care when you can make an appointment.
Right.
Whereas I feel like with you...
Good luck with that.
Yeah, right. Whereas I feel like with you really get into the diagnosis, how to get better, giving the proper steps to the patient to get better, and then you keep the employer involved with that process as well, which I think is refreshing, because it's a much quicker, we'll call it, mentally healing process for our patients, and physically, because they feel like they're being cared to, which is nice.
Yeah, if you think of having a professional athlete, would you send that person to an urgent care?
Yeah.
And if you did send them to urgent care, what would you not get that you otherwise would get from a high-level sports medicine practice?
Good example.
So for this, other states have a more deliberate, a more up-to-date workers' comp system than Massachusetts. I know we're the mecca of medicine. I'm right here next to Mass General Hospital. It should be the best medical care on the planet for everything.
Yeah.
But unfortunately, because of a political arena where they've not been able to update the Massachusetts workers' comp system for now 33 years, my field has been allowed to essentially rot on the vine. The infrastructure of OccMed has been allowed to deteriorate in this particular state. For example, I was able to place this clinic adjacent to Mass General, use their X-ray, use their electronic, records to do things. They don't care because they have zero outward-facing occupational medicine.
Right, right. You're not a
I'm
threat
not
to them.
competing
That's
with
right.
them.
That's right.
And why is that? Well, there's no money in it for
Yeah.
them. This hospital group is the largest employer, as I understand, in the state. They have internal OccMed, but they have zero outward facing. If you think about it, what if they had no cardiology? How could you do without cardiology? But yet we can somehow do without occupational medicine. That's fine.
Here you are.
Better for me.
That's right. That's right.
But anyway, I'll be glad to talk more about that in a minute.
So what industries do you service? Like, what if outside of construction, because I know you service construction, but
Yeah, there's a hospitality company. It's one of the largest hotel industries.
Mhm.
They are a big client of mine.
Okay.
They want to have their housekeepers and other staff cared for well. So that's an example. I happen to be an aviation medical examiner. I'm a senior AME, and then I'm a HIMSS AME, so I have more aviation stuff than I'd like.
Sure.
I do that. My nurse practitioner, Dina Stetson, just recertified with her DOT. She's very proud of that.
Yeah.
And so she does a lot of DOT exams, a lot of other surveillance exams. We do a lot of military readiness
Okay.
evaluations.
Sure.
A lot of for different government agencies. I have a background in not just the individual care, but in disability management. So I do the majority of disability evaluations for the state of New Hampshire, and I'm an in-house consultant for Massachusetts, the PARAC, which is the public employee, anybody that's on disability.
Okay.
So I have a few different things that I'm doing, but it's the injury care that I'm most passionate. That's the name of the company, is OccMed.
Sure.
Consulting and Injury Care.
Sure.
With the last being emphasized. So that's.
So, I would say when we first started working together back in 2006 or 7, the construction fields use for OccMed was strictly for, we'll call it post-injury.
Yeah.
We would have something happen, they would come see you, you would evaluate, and then give recommendations and diagnosis after that. But it's come so far. You do so much more than just post-injury diagnosis. What are some of the other things that a construction company, you would want a construction company to know that you offer that you can help them out with?
Before we go down the path of wellness, let's first talk about communication. It's not just the physician and the injured athlete or the injured worker. There are other stakeholders.
Sure.
And a good occupational medicine clinic will have a higher level of communication.
Sure.
Not just in writing. There should be a typed out work status report for sure.
Yep.
That's a must. But the secret sauce, the really important stuff happens in that moment when what I call the transactional face-to-face or transactional call. If the safety professional or the designated employer representative is not here in my clinic, I will call them.
Sure.
At that moment when I'm finished with the medical part, the person knows what's happening, the x-ray has been reviewed, and treatment has been recommended. Then the next question is, what about modified duty?
Yeah.
And if that's a possibility, then how do we bring that to fruition? What is that person going to do the next day? And if that safety professional can come on the phone or come in the actual exam room and discuss that in real time, then that worker leaves with a clear picture in their minds
Sure.
about what's going to happen and who to call if when they show up it's not what they expected.
Yeah.
Or because I'm not making widgets, I'm taking care of people, something evolves
Yeah.
and things change. That's incredibly important. The state of Washington, okay, they have one insurance company, the state, and they have studied this. And what the state has found is they have a performance driving process where they will pay the provider more if they do that transactional call.
Mm-hmm.
Because they found over time it saves huge amount.
Right.
And it's the ROI is way bigger than any money invested on the back end.
Yeah.
So if you take that front end, invest in that front end of the injury care when the person has just been injured. If it starts well, it's going to end well. If it starts poorly, chances are that particular claim is going to end poorly.
Yeah.
And it's all about the entire care cycle cost.
Yeah.
So a state like Washington State, they have like 4 or 5 things that if the provider does those things, they get more money.
Yeah. Sure.
Now, that works. Whether it's OccMed or primary care or urgent care,
Sure.
you know, you can say, oh, if you do this, this, and this, it goes from like, you know, $150 to $300. Versus Massachusetts, it's $100.
Yeah.
That's the DI rate.
Yeah.
Nobody wants to take care of an injured worker in this state.
Yeah.
Connecticut's twice that. New Hampshire's 3 times that.
Yeah.
Now, in Manchester, New Hampshire, there are six OccMed clinics. How many OccMed clinics are there in downtown Boston? Where we're sitting is the only one.
Yeah.
That's it.
Yeah.
And why is that? Because a nurse practitioner can see a worker in New Hampshire and she gets paid 3 times as much.
For those that don't know, that are listening, typically an incident happens on site.
Yeah.
And if they want to use your facility, a call is typically made from whatever project it is to you saying,
Yeah.
John, we've had something happen, we have an injured employee, they're going to come see you, they're going to come into the clinic, you're going to evaluate them, and you're going to work with that employee to understand their capabilities possibly of
Yeah.
how severe their injury is, and if there's some return to work capabilities at that point.
Yeah.
And I appreciate working for a general contractor, that line of communication you just established was,
Yeah.
you're going to pick up the phone
Yeah.
and call
Yeah.
the clientele, which may be some contractor or Turner directly or
Doesn't
whomever.
matter. Who's ever
And
knows
say,
that patient.
This is what we got.
Yeah.
This is what we're up against. And is there something available
Yeah.
from a standpoint of transitional or modified duty to get this employee back to work?
Or keep them at work.
Or keep them at work,
That's
right? That's right, keep them at work.
It's what we aspire to have, is to
Absolutely.
stay at work.
So, so how do you understand what may be available on a construction site for modified or transitional duty?
Yeah. So again, especially when I first started,
Yeah,
I would go to almost every major job site,
I know.
walk through. I would want to have a first name rapport with the safety professional.
Yep.
And, you know, I have subcontractors that are iron workers, and I would walk around with those guys and say, okay, tell me about what this means when you're plumbing a building.
Yeah.
This is fascinating.
Yeah.
And so then you have the language, you have the, and so every day a worker's surprised when I say, oh, you were next to a whaler.
Yeah.
You're not gonna know what a whaler is.
Right, right. They're looking like, what? How do you know?
Who knows?
Yeah.
Yeah,
Yeah.
and then, so the conversation changes when they understand that I actually
Yeah.
know some of that stuff.
Yeah.
And I feel like I can provide better care.
Sure.
And when they describe the mechanism, I can understand it better,
Yeah.
So that's one aspect. That I've been to the work sites.
That's right.
And I make a point to have rapport with safety professionals and quite frankly with the union stewards.
Yeah.
Whoever it is that interacts with that person on the job site, I will partner with them. I will see them as a stakeholder.
Yeah.
Because, look, it takes a village.
And at the end of the day, getting that employee that was injured back to 100% is everyone's goal.
Well,
It's
actually-
yours, it's the contractors, it's the employees, I hope. I think.
Actually, I'll go one beyond that.
Okay.
I often want to get them better
Okay. There you go.
because that's how I prevent the next injury.
There you go.
I'll give you one small example.
Sure.
Worker comes in, he's cut his hand. Why did he cut his hand? No glove fits him
Okay.
because he's got hands they look like snowballs. They
Okay.
look like the snow cones.
Okay.
Okay, because he's got congestive heart failure, he's blown up, and you can't put a glove on the guy.
Okay.
So he's working without a glove and cut himself on bracing.
Okay.
Okay, so I took care of the cut,
Sure.
but I said, okay, look, you've got edema in your legs, you've got sleep apnea,
Yeah.
we need you in your primary care doctor's office, and I'm gonna help you make some calls.
Sure.
So he's probably got 30 pounds of water weight
Yeah.
that he's trying to carry around.
Yeah.
It's one thing for the person's wife, significant other, even primary care doc, to harangue them over time. But it's another thing for someone they don't even know to put two and two together.
All together. Yeah.
And I can't tell you how many times I'll see someone with like a low back strain.
What?
And I'll say, where are you going with this?
Yeah.
One example is there was a 23-year-old just starting out as a laborer, pudgy, doughy face. He picked up something that had a strain in his back. He's 23 years old.
Yeah. Shouldn't be straining his back
I
right.
said, really? Where are you going with this?
Yeah.
You want to be a laborer, you know what?
Yeah.
You should actually get your physical plant a little bit more resilient for
Yeah.
this work.
Yeah.
And so about 9 months later, I was literally on a Turner site in Cambridge. And after the talk, whatever I was talking about, up from the crowd comes this young man with a nicely cut, chiseled face. And he says, look at me. I looked at him, I kind of recognized him. And he just picked up something heavy and walked off.
Yeah.
That's it.
So you had an impact, obviously, outside of,
He didn't
care.
say thank you.
Yeah.
So
Yeah.
there are levels, hierarchies of prevention.
Yeah.
And primary, secondary, tertiary. And what I've just alluded to is secondary and tertiary.
One of the common misconceptions is as a general contractor, if someone gets hurt, they want to make sure they're getting the very best treatment. And they think that you're working for Turner sometimes, that it's the OccDoc or whatever. But, it's refreshing to me to hear the story you just told about you were evaluating somebody in here
Yeah.
on a lower back, and
Yeah.
a year later you were out on one of our sites.
Yeah.
And you happen to run into them
Yeah.
doing something else on site, probably touring it or education or whatever,
Yeah.
and you saw them, and that's the level of commitment you bring
Yeah.
to this
Yeah.
industry.
This is a community, and the people that are at a Turner site, or it doesn't matter, it could be Skanska, it could be
Yeah.
J&A, it could be whatever. They're going to be at another site and another site,
Yeah.
and it's a workforce.
Yeah.
And what should we do to elevate this workforce
Yeah.
over time?
Yeah.
And and to help those workers age gracefully, because I often say, okay, great, you're 35, how are you gonna get to 45?
It's a long, hard career. It's a long,
what's that
hard
going to
career.
look like? And what do we need to do now, today,
Yeah.
to help us get to 45? And
Yeah.
by the way, what happens after 45? So what you do as the 35-year-old,
Yeah.
you're getting your, your set points together, you're getting your habits. And so I point out a few things here and there, by and large, people are appreciative.
Yeah.
If
Yeah.
someone comes here and then they actually come back for a follow-up, well, that's a success right there. And if they actually come to my office willingly,
Yeah.
because Massachusetts is a choice state,
Yeah.
they don't have to come here. And if they then come back and they look around and they think, oh, okay, this is a place where I can get better, then that's a huge win.
Yeah. For me, on the EHS side of it, again, our goal should be to get these folks back better than they were, right?
Yeah.
Not back to normal, but better than they were. And but at the same time, there's some value in having these employees return to work as opposed to going out on a lost time.
Well, to stay at work.
To stay at work.
That's
right?
actually a term, stay at work.
Stay at work, right?
Yeah, that's a current disability thinking.
Yeah. Well-
And that takes a machinery, that takes an effort on the part of the safety professionals.
Yep.
It takes an effort on the part of the union.
Yep.
When we first started doing this, it was your colleague, Admin Friend.
Mhm.
Do you remember him?
Oh yeah.
Yeah, it was a project for MIT,
Mhm.
and Abden and I both made great efforts to have the stay at work part.
Mhm.
And at the end of the project, the cost per man hour was a fourth of 3 or 4 other projects going on at MIT at the time. And we had this one pie chart where it said 85% no lost time. And the moment any other GC would see that, they would immediately realize its implications for their experience modifier ratio.
Sure.
And then my phone just, it was just,
Yeah.
okay, everybody else wants that. It quickly became the standard of care.
Right.
And that's I think, the nucleus of how I started my company.
And part of achieving success in that, because I'm sure that the company that the employee works for likes that because the employee's back to work, but also is the communication, I feel, that you discussed earlier.
Yeah.
Setting up that program at the project level,
Yeah.
that all the vested parties, steward, injured employee, the company they work for, the general
Yeah.
contractor, all agree that if they're gonna stay at work, that there may be a transitional or modified duty.
Must be.
Must be, right?
And first question when the worker comes back, how are you doing?
Yeah. Are they being fair to you?
How much better are you?
Yeah.
And tell me what you're doing at work.
Yeah.
And if they say that, okay, they were supposed to be on the ground and they're climbing ladders,
Yeah.
I say no bueno.
Yeah.
Let me
Yeah.
rattle cage.
Yep.
And sometimes, quite frankly, I've had to fire clients for not being forthright and for not respecting the modified duty.
That's right.
And if I don't like their safety program, I remember one company, I won't name the name, but there was a machine that fell on somebody. And the worker had said, that machine is faulty. They didn't pay attention to him, the machine fell on him, and then after it fell on him, I said, there's a safety issue here. They didn't, do all the right things. And I got a call from their vice president while I was at home working on a shed in
Mhm.
my backyard. I said, I'm sorry, I won't be party to that.
Yeah. Yeah. No, I mean, you like to think every company's gonna do the right thing by their people, but not everyone's out there to do the right thing by their people, so that's where.
Most are.
Yeah, sure.
In
Yep.
Boston.
Yep.
Impressively so.
And then there's such a strong union presence here too. They look after
Yeah.
their people so well. I mean, so
Yeah.
it's the confidence, it's the backing they have with the union too.
Yeah, bad news
Um,
travels fast.
That's right.
And I wouldn't
right.
be able to see anybody if, the unions can't really articulate support for a given provider,
Yeah.
but they can very much articulate
Yeah, that's right.
that they're not inclined to,
That's right.
yeah, so. Back to your question of the wellness, how can we extend that philosophy? How can I broaden the scope and, certain general contractors in this state have, I think, done an admirable job thinking about that. We've tried to innovate over time with that because the need is there. Unfortunately, the construction worker's time frame is he gets up very early. Only a small percentage can go exercise before they start work. They're not really in the same place. They can't get to the gym over their lunch break. They have more barriers to consistent physical activity than other occupations, but yet they need it more. They're aging. Sarcopenia means the muscle mass atrophies as you get older unless you do something to counteract that. This happens, and the worker that does the same thing every day does not, the body just gets immune to that. They don't get full credit for that activity, unfortunately. And so it becomes a problem when they have that first injury, and then they try to accommodate for that, and they alter how their movements are, and it can snowball rapidly.
Sure.
So that's kind of what you want to
get ahead of.
Attempt to get ahead of. There's often injuries where it seems like one small thing, but to get that worker better, really better, at a functional level where he can do the job effectively, you have to think about their whole picture. And that's why I think I'm fortunate to have a primary care background as well. And I never say don't go to your primary care. In fact, the opposite. Please take my note to your primary care. And by the way, have them check your thyroid level. And guess what? Your BMI is 38. The likelihood of you having sleep apnea is quite high. Have them talk to you about that as well. There's a test for that. You can get treatment. And then all those difficulties controlling your weight will be a lot easier if you actually treat that.
Do you think there's a psychological benefit to stay at work versus go out of work if you can avoid it?
Yes, there's evidence base for that. The Israelis, during one of their wars, they took everybody that got injured away from the front lines and put them in a fancy tertiary care hospital, and none of those people ever went back. Another war, they said, we're not doing that again. They kept them with their unit, and they had a much higher success rate. So-called SPICE model, and in occupational medicine, there's an evidence base for doing just that. And it's a real thing where you get your comrades. There's positive as opposed to negative if you're sitting at home watching, the commercials on daytime television.
Sure. There's a little bit of self-worth probably. That you're back with your folks. You're working. You're contributing to the team. You're still part of the team as opposed to being removed from that.
Recovery is as much. Between the ears as in the back or in the knee. And you wouldn't think construction workers, male or female, would have drama and insecurities, but they do. They're humans.
Like anyone else, right?
Yes.
And everyone's journey is a little different, like you said, because
Everyone's
if you're
journey
a
is-
little younger or better in shape, you may have to get that quicker or...
And it depends sometimes on if they've had a major trauma in their lives, because they'll almost get flashbacks. I've seen that many times.
Interesting.
Yeah, the level of anxiety will be greatly increased if they've had a major injury, and they think that they're going back down that road. It's not just the pain, it's the
recuperation
immobility,
time.
it's the impact on their families. We all have our insecurities, and not being able to perform their trade is a real insecurity.
And provide for their families, I'm sure, and all
Et cetera.
that.
Their life's just not as fun.
Well, we always talk about too, getting hurt at work on behalf for an employer isn't the way to go about business, right? You want to be able to go and leave work and provide for your family and do your extracurricular activities and go hunting and fishing, play ball with the kids, or whatever else.
And if you can't do that, life is not as fun. And you think of musculoskeletal, whatever, it's just a sore hand or arm or something, but it impacts. You can't pull a bowstring. If you've racked your shoulder.
Doing what you love, you can't. Your hobby, on the shelf.
If you can't play in your hockey league, then you can't have as much time with your buddies.
That's right.
So it's impactful.
So a lot of the GCs, general contractors in Boston, have started to have a wellness professional to some extent
Yeah.
on their projects or associate with, just their companies. What's your role with integration with them, and what do you see some of the benefits at the project level to have that wellness provider?
Well, it's interesting. Again, having been involved with caring for tradesmen as long as I have, at first it was like piecemeal. We would have a little discussion about hypertension here, or a good diet there, and it was like catch as catch can. But there's actually a whole field of prevention, and you can do health risk appraisals, and you can think about it in a more organized and deliberate fashion. And so I connected some of the GCs with organizations that have some expertise on that.
Mm-hmm.
And we had to kind of get them to do the basic things that a on-site person would do in terms of triage of injuries, and if they have any kind of urine drug screening, to do that.
Sure.
But the wellness piece is significant, and it requires a higher level of background. These individuals have some of the best insurance coverage on the planet, yet they don't take the time to use it.
Yeah.
And some need it.
Yeah.
Some don't need it,
Yeah.
but some do need it.
Yeah.
And to tell them that they need it, and to articulate why they need it and what the benefit would be for themselves and their families, that's significant.
Yeah.
And to help that
Guide
process.
them to that process.
Yeah.
Taking advantage
Yeah.
of the union opportunities or healthcare, or
Yeah.
just giving right information on site. Yeah.
Yeah, I mean, we're a lot of middle-aged, men. There's no real advocate for that.
Yeah.
And not to pick on the men, but they're a paycheck,
Yeah.
bluntly stated,
Yeah.
to themselves, to their families, to the world around them.
Yeah.
They're a paycheck,
Yeah.
but they need preventive maintenance just like a car and anything else.
That's right.
No, they don't have to get a pap smear,
Yeah.
but at least think about sleep apnea,
Yeah.
low testosterone,
Yeah.
and the other host of things that can be a problem
Yeah.
for a man as he ages.
I mean, they're not sitting behind a desk all day. They're out doing physical.
Good.
They're an occupational.
Which is great.
Yeah.
Which is great,
But their job is hard, and they have to keep up that
Yeah.
maintenance like you're talking about.
and to age gracefully
Yeah.
is not. You have to be deliberate in your thought process.
That's right.
Some have a good plan.
Yeah.
I see people every day that they're 55, but they could be 35,
Yep.
or they're 65 and they could be 45.
Yep.
That's great,
Yeah.
and let's keep them that way. And if they get injured, treat them effectively, so that they can maintain that. Others, like the guy with the snow cone hands, he needs help.
Yeah.
He's a danger to himself and others.
Yeah. Yeah.
And it's not just maybe someday. It's like every shift, this guy is at risk.
We do work with a subcontractor, obviously one of our subs, and the owner's adamant about employee well-being.
Yeah.
And basically his philosophy is he feels like if his employees are invested in themselves,
Yeah.
they're not gonna take shortcuts. They're not gonna expose themselves to getting
Yeah.
hurt, because they're investing their time, whether it's
Right.
gym or whether it's wellness or well-being. And I've kind of, over the past 10 years, I've really appreciated that, because we can see the people on site that are thinking that way, are invested in themselves, have hobbies outside of work.
Right.
They don't want to get hurt.
No.
They don't want to take the shortcut,
Yeah.
And
Yeah.
but to get there, there's
Yeah.
some strategy behind it,
Sometimes people need a teeny bit of a nudge.
Yeah.
They're contemplative,
Yeah.
but they don't see a clear path.
Yeah.
They have too far to drive. I've told not to know how many, is you can actually exercise while you're driving.
Yeah.
First off, it'll keep you from falling asleep, and you can YouTube it. There's like little balls, and you push this way, and you squeeze this.
Sure.
And you sit this and that way. And sometimes I'll even say, look, all those cars have seats with a backrest, but you don't have to use the backrest.
Yeah.
You can sit up, and
Yeah.
you've engaged your core,
Yeah.
if you think about it.
Yeah. Sure. No,
Yeah.
it's all those things, and that's one of the big things in the construction industry we hear is they wake up early, to your point, like you
Right.
said. They're working through lunch, they work overtime, and by the time they leave work, the bank is closed, the
They're
gym
done.
is closed, they can't get a
Yeah.
haircut,
Yeah.
it's just a lot of hours, and but
Yeah.
quite frankly, at the end of the day, they're tired.
They're tired.
They put in a good day's work.
And their family gets home, and their families want their, piece of
Yep.
them.
Yep. Yeah.
So how do you get that in? At some projects, we've had gyms. We've tried that.
Yeah.
Outdoor, indoor.
Yeah. Yeah. No, and that's the I guess the benefit of this wellness program that some of these contractors are trying to run is just find the niche to help these individuals have an opportunity to come in, step away while at work to go talk to somebody or have a farmer's market on site or whatever the program is for that month.
To make it accessible.
Yeah.
Right.
Yeah, fresh vegetable, whatever it is. I mean, So I just, I thought this was a good opportunity to get you in front of the folks listening today and watching and just have a good conversation predicated around occupational medicine, the things you provide to our construction industry that many people may not even knew existed or knew exactly what it was.
I would, the summary comments I would make is there is evidence base about how to provide care to injured workers. And that evidence base has not infiltrated the Massachusetts workers' comp system. There are some good aspects to it, but there are some other aspects that are archaic. Yeah. And my company, I started it to try to provide a benchmark to other states that have a more up-to-date workers' comp system. The system matters. It affects how care is delivered. If the reimbursement rates are so low that the person can't access good care, that's a problem.
Yeah.
You pay peanuts, you get monkeys. The things that I've talked about that I think impact care, and I can point to evidence base for, there is no ability to reimburse for that in the current system. Zero.
Yeah.
Other OccMed clinics in this state, they try to maintain less than 20% of their volume be injury care. The reason for that is they can subsidize with fee-for-service stuff, but if it gets above 20, they will go broke.
Yeah.
They'll have to close their office. That's not a good situation.
Yeah.
And I fault state governments' recalcitrance on that. There are physicians in this state that are making out great.
Yeah.
They can negotiate for their procedures, and then there's other physicians who are not doing so well.
Right.
162 above Medicare percent versus 13% below.
Right.
That's where workers' comp is reimbursed in the state. If you know that one, then you have to think, well, how do I prepare for my injured workers? Where can I have them be seen? And what is the reimbursement for that? And how can I ensure that somehow I'm getting the level of communication? Because that can impact, by the way, what is OSHA recordable and what's not.
Right.
Is the person seeing them cognizant of what it means about OSHA recordability?
Right.
An emergency room physician knows nothing of that.
Right.
An emergency room physician, all they know is HIPAA.
Yeah.
And they don't even know that with a workers' comp claim, HIPAA is flipped. You're supposed to communicate details that are pertinent to that injury. I'm not going to talk about the fellow's HIV status.
Right. Right.
But if it's pertinent to that claim, then that can go in the note.
Right.
And then any stakeholder that's involved in that care should have that note as a form of communication. Now, others might not agree with that stance, but I do.
Yeah.
And I've used that philosophy to good end in the service of these workers.
Yeah. No, I mean it's interesting. We didn't really talk about OSHA reportability other than stay at work versus a lost work day.
There's other things that go into it.
Yeah.
Prescription versus over the counter.
That's right.
If you're taking care of an eye injury, okay.
Yeah.
There's factors and ways of doing it. Now, if the person comes in and this, all the layers of the skin are interrupted and they need suturing, then that's it.
That's right.
We're going to suture.
That's right.
We're not going to not do something to make it not OSHA.
That's right.
But the difference is, I'm going to tell you exactly why that needs to be done in this way to justify it, so that the safety professional can then go and tell whoever's interested,
right,
breathe them down their neck about it.
Right. Right.
At the end of the day, it's the care cycle that counts.
That's right.
And does the worker come out of it with some type of chronicity that impairs their ability to derive their livelihood?
Right.
Yes or no?
And I can see and I appreciate your candor with the conversation because, you know, certain contractors out there may want to try to avoid that OSHA reportable as much as they can, which is everyone's goal.
Yeah.
But to have you knowledgeable on how to do that is great.
Yeah.
But you can't do so while you can't impact the employee's care
Yeah.
over that decision.
No, the worst thing is some situation has occurred and there's an iatrogenic disability that comes of it. Iatrogenic means the care has somehow caused the disability.
Yeah. Glue versus sutures.
That's just not right.
Yeah.
Yeah. So right. Yeah. If you use tissue glue on a hand in a construction worker, well, what's that going to do?
Yeah.
It's
Open
not,
up.
It's not.
Yeah.
It's not going to. It's not going to go. Now, if you cut yourself right here, fine.
Yeah.
Okay, fine.
Yeah.
If it's not gaping,
Yeah.
the muscle's not involved, fine.
That's a benefit you have too that's
Yeah.
attractive to contractors is you have the knowledge to know what
Yeah.
OSHA record keeping standards are
Yeah.
and how you can navigate in and out of those standards.
Well, and how I'm going to provide care, and I'm going to avoid an OSHA recordability that doesn't need to be.
That's right.
But when that level of care is necessary, I'm going to tell the safety professional exactly why, so that he or she can then communicate why that is. And so everybody's, okay, can
Yeah.
sleep well at night, knowing that they've done their job.
Yeah. What's your stance? I think this is probably the last subject we touch upon. We can break, but and that was a great conversation there. What's your stance on with the epidemic today with substance misuse and prescribing medications? Like, what's your ideology there? What's your thought philosophy when it comes to that?
So, in brief, I was involved in guideline creation for this state. I serve on the Healthcare Services Board. I helped to write the medical treatment guidelines. Right now, we're finishing up the knee guideline. There was an opiate guideline that we did.
Sure.
And at the time, I was also the chair of the Public Health Committee for the Massachusetts Medical Society and served on the task force. And I actually was participant on Charlie Baker, the governor then,
Yeah.
on his opiate task force. And long story short is we wanted to have equal narratives about how to approach that. And from the worker standpoint, there is no good reason to prescribe an opiate for the vast majority of injuries.
Sure.
There was a study done in New York right before the COVID pandemic that found if you combine Tylenol and ibuprofen together at the over-the-counter dose, it's equivalent analgesic effect as a Vicodin. And I think you're aware, I give talks on reasonable suspicion training,
Sure. Yeah.
and I have a slide in there that shows how addictive, our prescribed opiates are.
Mhm.
It's basically no different than heroin. And why would I do that
Right.
if I can use Tylenol and ibuprofen?
Right.
Which, by the way, that doesn't even have to be OSHA recordable.
Yeah. There you go. Yeah.
No, it's awful. They were physicians.
Alright, sorry, I don't know what that was.
You were asking about opioid
Yeah.
related issues, and,
Yeah.
and I said I have some background in that. I helped this state with regards to their guidelines. And long story short is, there's been a sea change from people overprescribing to attempting very diligently not to prescribe.
Use other methods.
Use other methods, as I mentioned, the
Yeah.
over-the-counters,
Yeah.
the sleep in a chair if it's a shoulder, for example. There's actually a database you're supposed to enter in. Like I have a worker right now with a fractured leg, and I'm probably going to provide him with some tramadol. And I'll have to put his name into a system, a database. And the purpose of that is if I look at it, I can see if he's been a frequent flyer
Gotcha.
of the opioids, and I know not to prescribe.
There you go.
So there's some built-in measures, safety measures.
Sure.
I was actually working for the Commonwealth of Massachusetts part-time in their workers' comp unit, and I helped to pull back, intervene on, legacy high opioid cases, people that had huge amounts of opiates, so high that they were at risk for dying in their sleep from respiratory depression.
Wow.
And we actually had a guy, we were trying to intervene, and he wouldn't comply,
Yeah.
and he died.
Yeah.
Yeah.
It's scary, and again, we appreciate that because if we can keep our employees away from that as much as possible,
Yeah.
then there's no epidemic. Hopefully that goes away. The more we
Yeah.
use alternative methods,
Right.
which is refreshing. So
Yeah, and by the way, if they're getting better and they're reassured that their function is improving, they're less likely to go down the escalation of opiate route.
that's right.
And I actually ask, have you had any history of addiction? And if they've had a history of addiction, then don't prescribe.
That's right.
Because, we don't give pregnant women strong medicines that affect the baby.
That's right.
Why would you want to cause a relapse?
That's right.
Having said that, if, there's other cases where you need to, you take them off their medication-assisted therapy, treatment, and treatment for a short period of time. But it's monitored.
Yeah.
It's very deliberate. So there's ways of taking care of an injury,
Yeah.
even if someone is on medication-assisted treatment for opiates.
Yeah.
But anyway,
Just another thing that I'm thankful that you're in tune to, because this
Yeah.
is something that has plagued our industry for the last 10 to 15 years anyway. So it's
Yeah.
good to have that alignment with you and
Right.
your ideology on that, which is nice.
yeah.
Well, I really appreciate you taking the time here. I think, with some great answers to, hopefully we enlightened our listeners a little bit on just occupational medicine, how
Yeah.
the relation with construction, the industry, personnel, those sort of folks. So hopefully folks got something out of this.
Yeah,
And,
hopefully so.
And then, again, John Burress with OccMed CIC. If you have any further questions, you can reach out to myself or John directly. I'm sure he'll be happy to answer those. But we thank you for your time, and hopefully this was beneficial to you.
Doug, thank you.
Thanks, John. What do you think? Good. All right.
Hopefully that
That's awesome. And they